our study was to combine selinexor, Espovio, to carfilzomib and dexamethasone in heavily pretreated patients, so using selinexor as a new backbone. And the objective of our study was to determine the maximum tolerated dose of these three agents combined together, and the recommended phase 2 dose for the expansion phase of the study to determine, of course, the response, the effectiveness, and the toxicity of Espovio given in this combination. So, you know, as I mentioned, this was one of the arm of the STOMP study. The STOMP study is phase 1b, phase 2 study where selinexor was combined with different anti-myeloma therapies. And so patients enroll in each arm, you know, they were enrolling each arm based on the prior lines of therapy. So for instance, in the carfilzomib arm that I presented at ASCO and HIHA, patients were carfilzomib naive. So we were able to accrue 32 patients. And then in the first portion of the study, we were combining selinexor with carfilzomib and dexamethasone weekly to determine the maximum tolerated dose. So we actually had 3 patients included in the first cohort where selinexor was given at 100 milligram. And then we found, unfortunately, we had a couple of DLT at that level. So we de-escalate the selinexor, and we determined that the maximum tolerated dose was 80 milligram in combination with 56 milligram of carfilzomib given every week in combination with dexamethasone. So, you know, the first portion of the study was to enroll patients to determine the maximum tolerated dose, and then we expanded the study on the phase 2 portion for effectiveness and other safety signal. So we determined that the recommended phase 2 dose was selinexor 80 milligram given every week, day 1, 8, 15, and 22, in combination of carfilzomib 56 milligram per meter square given weekly, 1, 8, and 15, and dexamethasone also given weekly. Yes, so first of all, this was the primary objective of the phase 1 portion was the maximum tolerated dose, the recommended phase 2 dose, which I mentioned, and the secondary endpoint was safety, tolerability, and then, of course, progression-free survival, overall survival, and actually the primary objective, of course, overall response rate. So it was clear that the combination was effective. We enrolled 32 patients with a median number of 4 prior therapies. They were all exposed to bortezomib, a fair amount to lenalidomide, pomalidomide, daratumumab. 0.5% were refractory to daratumumab, which is a very difficult population of patients to treat. And so we determined that the combination was effective. We actually had an overall response of almost shy of 80%, and 1/3 of patients achieving VGPR or better. So we had really a good signal, a good combinations. And the progression-free survival, which was one of the key secondary objectives, was 15 months for all patients, including The high risk cytogenetic, of course, a very small number, only 32 patients. So 15 months, and for patients with triple class refractory was almost 2 years. So we were very pleased with the results. So, this is a very initial small study. We were trying to determine the safety, tolerability, and then if there was a synergistic effect in combination with carfilzomib. We know that XPOVIO works synergistically with proteasome inhibitor. It was recently approved based on the results of the Boston study in combination with bortezomib given weekly. So carfilzomib, it's is a important, powerful drug that we use in the myeloma. So we wanted to explore the safety of this combination. And these, the STOMP study is leading to the development of larger study. The Boston came out of the preliminary results of the STOMP. We combine XPOVIO to Velcade, and then that generated the Boston study, the design of the Boston study. So hopefully, we will have, with these preliminary results, the opportunity to expand this funding. I think this is maybe is going to become an important combination, is a new backbone for patients with relapsed myeloma. So we'll see in the future. We are thinking about exploring this combination in a larger study. I would like to briefly mention about the safety profile, if you don't mind. It's clear, selinexor causes a fair amount of GI toxicity, constitutional with fatigue, weight loss, nausea, fatigue, as I mentioned, and some myelosuppression, particularly thrombocytopenia. And the fact that the selinexor was given orally once a week in this combination, we've seen the same safety toxicity profile, but mitigated by the fact that the selinexor is given at the lower dose, 80 milligram, and only once a week. And so this is very important for patient safety, tolerability, and in fact, looking at progression-free survival and duration of response, we had patients remaining on therapy for a prolonged period of time because the tolerability.